Yes, please.
Considering your comment about the eyes being a sensory device to help us know where we are in space, have you included in any of your study, or you plan to blind people who have OT, and the absence of sight and the fact that they have learned to overcompensate for the lack of sight may give them other sensory techniques to deal with their trembling and their shaking?
That's a great question. So everybody heard that? Yeah. That's a great question. So the question is, can we retrain? I guess the question is, can we retrain OT patients into using other senses beyond the eyes to be able to feel better in space and not feel that they are falling? That is one of the scientific questions that we have, and one of the studies that we want to do is actually to do muscular retraining programs that would address that particular question. So things like yoga, stationary yoga, because standing yoga is not good for us. But yoga in the floor and seeing if increasing the awareness of your own body can help us. There are not too many senses out there that will help us with this. Vision, hearing, and the true regular sensations coming from the legs and the arms. Because the others, sniffing and taste are not going to be very helpful. So we really, a third of the brain deals with vision. A third of our brain deals with vision. So vision is very powerful. I wonder, one study that we have been very interested in doing is checking for OT in blind people, right? Because by definition, they should feel unstable.
We have at least one such person who is legally blind.
I know. And guess what? It tore apart my heart to tell this person that she wasn't able to come to the study, right? Because of the particular study we're doing right now. But that's something that I would love to meet her. It was just really hard. But yes, those are incredible questions, and I think we'll need many more scientists interested in OT, because in reality I cannot do it all. It took 3 years of planning to be able to be where we are right now. Yes.
Okay, they have like a pacemaker for your heart, and your heart rhythm is acting up. Okay, is that what the brain stimulation thing that they talk about?
That's a great comparison.
Stimulate the brain or to regulate the brain waves for that?
Yeah, that's a great comparison. Yeah, that really works. It works like that.
Okay, I just wanted to ask you, with all the advances in DNA, have you ever thought about taking the DNA from all the OT people and comparing the area that deals with mobility to see if there's any in common with this DNA?
So Peggy's question is, have I ever thought about grabbing a DNA sample from all of you and running it and see what's different between you and normal people, right?
Or what we have in common with the OT people?
Yeah.
In the area of the mobility, you look at that, or not?
So usually that's a lot easier to do. There is a paper published by Pullman, Seth, in OT that reviewed this particular question. It is a lot easier to study. There are millions and millions and millions of genes. There is no gene for stability, right? Stability might have maybe 1 million genes that you need to be able to maintain stability.
Like for mobility, is there?
Yeah, no, there's no specific gene for mobility. This is what we call a multi-gene, issue. So it's a lot easier to go back and study a disease that is familiar in nature and then decide to do genetic testing on them. As I said, there are only 9 patients reported with family history of OT that we could study, and that could be very useful. At the same time, my boss here at the University of Nebraska he got very excited about this. Dr. Dan Borman, he's also a movement disorder expert. And a lot of people are getting excited about autism, so that's great news. And he said, Diego, I think we should do a repository of DNA of all of the patients and start working on that question, because we have the capabilities. We have the people at, we have a genetic center at the, it's called the Monroe Meyer Institute here that would be able to run those tests and do the status. So that's something that is in the works in the future. And as you know, so this study will produce many.
Is that just for the families you're talking about now?
Not for the families, for everybody. Just exactly what you asked. Yeah, that's right. But so it's something that is going to come with this new phase that we're planning. The new phase of what we're planning is we need an international repository of OT data localized in a single place that will provide access of the data to any scientist that wants to work in OT, right? Because I don't want to do it all, I cannot do it all, right? But if we're able to collect all data about proven OT patients in the world, right? And have it in a prospective fashion, that we're collecting every single piece of information that we need, and then that repository make it available to any scientist that wants to review particular associations and that data, and also pair that data with DNA. You see, that would be so that's our next step. That will come in the next 3-5 years.
Would you address the panic or anxiety issue as it produces more tremor, and then the tremor, because of the tremor you get more anxious, and because of your anxiety you get more tremor?
Yeah.
Could you address that?
So last night I was late for dinner because we were done. And it was actually Dr. Bahati's Christmas party, the Eid day. They Muslims, have they have their own celebration yesterday that I don't know anything about. But he was working, the poor thing, and he wanted to go home as desperately as I wanted to go to the restaurant and join you guys. But at the same time, we were sitting down, reviewing the data and reviewing the preliminary data and seeing, oh my God, what have we done? It's like Frankenstein. When Frankenstein got up, he said, "Oh, what I have done!" Yeah, it was amazing. So the first thing we addressed was this issue of the panic, of the fear factor, and how that has never been published, in papers or studied in a proper fashion. And we felt that should be the first thing that should come out. And we said, why don't we work on that as the very first abstract to be sent to the Movement Disorder Society meeting that is, the deadline is January 6th or so for the next meeting in Australia. And even without doing the second batch, so just sending that all out so people start knowing, that there is a fear factor here that has not been communicated before. So yes, the answer is yes, we're definitely working on it. And it might be the first thing that comes out of this.
Yeah, I'm just wondering how you would be working on the fear factor, how you would approach that.
Yeah, because
I think it's a very big thing. Yeah.
I think that the main question is, if it's a fear problem, fear can be fixed, right? But we're missing the ball completely here. We have been trying to fix the shaking, right? We haven't addressed the fear whatsoever. But by the way, the drugs we use for the shaking might help with fear too. So maybe that's how it's working, you see? there are so many questions that have been unanswered. So, we ask very particular questions to you guys. How does it feel? How do you feel in closed environments? How do you feel when you don't have an open pathway in front of you? For walking, do you need to walk slow or fast to feel better? Those kinds of things are very important. And then the eyes open, eyes closed. There is something that you probably did notice that we were noticing, and it is how many centimeters apart your feet are when you stand up. Without thinking, we tell you stand up. You know how many times we ask you to stand up, right? You suffer through that. So in one of those, we actually measure the distance of your feet, right? That is a sense that gives us a sense of how scared are you of falling, right? Now we compare that with the distance of your feet apart when you are walking, right? Because the distance of your feet when you are walking is actually less than 10 centimeters. It's very, very close. And that's normal. But all of you, at least the ones I did, had very wide stance. Just like that. Why? Yeah, exactly. But as soon as you start walking, then the what we call the base of ambulation was normal. So see, we did so many things, we tricked you in so many ways. Yeah, that you didn't know. But so those are ways that we address the question.
Did you address how we curl our toes into the rib floor?
We didn't, but
We all did that.
we didn't, but so many, yeah. It's just
But
fascinating.
did you notice it, or, it'll show up on the films, but
Yeah, so that is just hard to review, right? It's hard to study. But there are ways of doing that on what is called a balance, a gait analysis, and that's something that could be done in the future.
Is there a brainwave detection system that would allow you to measure panic? How much panic a person is feeling? Or no panic, or some panic, or a lot of panic?
Yeah. I'm not a psychiatrist, okay, so that's one problem, that in science we have been dividing feelings from sensations, which is a problem, It is a true problem because it's all in the brain, right? So that would be a question that we would ask a psychiatrist. See, if we find that in fact panic and fear is a problem, then the next step for me is to find a collaborator in psychiatry that will help me understand that. And there are some, there is called, there is a study ongoing on that, transcranial magnetic stimulation, where we can, produce a change in the brain that can alter OT. And we don't know if what is altering is the, the sensation or whatever, but those are fair questions, and we just have to work on them.
I was just going to say that, what you might want to think about next time is having us do the stuff with no shoe and no socks on. Because like Patty said, we all curl our toes.
We do.
And then you can see with no socks on how we're just desperately cleaning with our toes.
So you had socks.
I have socks on.
See, I
On bare feet. But if you had everybody in bare feet, it's just a thought. Because then you can see when you're taping it, you want to see that we're just cleaning.
It's just to keep us there.
but that was one of the factors there.
Yeah. See, that has never been published. Right? That has never been published, the fact of the toe curling. And it has never been studied properly. You're saying all of us curl our toes, but that's something that
Ask us.
I don't know. We have, so yeah. So Harriet doesn't. Okay, how many don't? I guess is the question.
Funny.
Yeah, I think.
How many don't?
How many don't?
Yeah. Okay. So yeah.
And you lock your knees. You lock your knees and you curl your toes. You lock your knees.
There's one sensation
that I don't think we've addressed, and that is going down an incline, which is most difficult, and that sends us a message of a little bit of a panic too. We can't deal with going down an incline. We can go up a lot easier.
So Gloria is asking, not asking, actually suggesting that there is one thing that we haven't reviewed, which is that oftentimes OT patients feel worse when they're walking down on an incline down than going up, right? Okay. Well, those are things that have to be studied, and I'm paying attention to questions. Yes.
So, when I understand that your approach to this study is strictly neurological, and although you had physiatrists that participated and conducted the study, you're not examining it, and there's nobody from the university that's going to examine it on the presiding part. You're not looking at the muscles that are used or the compensations that the patient.
Yeah, no, all of that will be reviewed. Will be reviewed.
With the study.
And that's why we videotape all of that. Now the problem is that, Bob asked a great question yesterday, to the therapist. Did you end up knowing who was who?
What?
Right? He asked a question to the therapist last night. How can you really stay blinded? I mean, you had to know who had OT and who didn't. Right?
Yeah.
So one of the therapists said, well, I think that this and this patient, the first two, had OT, the last one didn't. That therapist, all of the patients she did that day had OT. And then the other said that, she had problems with one person, didn't know if the patient had or not OT. So I feel that the blinded was okay, because in fact the majority of people we did had OT, right? So it made it harder for them, because most of what they were seeing were OT, control, OT, and control, and they, So that made it harder for them. But beyond that, we're going to be reviewing. So a doctor and other therapists that you have never met are going to be reviewing all of those videos by themselves, and they have no idea about you or who has what, and then addressing that in a blinded fashion. But beyond that, we can always, and we will, go back to the videos and review new data that we want to do. For example, reviewing the toe curling issue, and see how many do and when. If it's when they're standing, when they're walking, how does that work, and so on and so forth. So we have an immense amount of data that we can work on. So
Pretty many of the control people here were normal people. I mean, that because they didn't have any really problems. But I know some of my friends have like arthritis and they could probably walk, Parkinson's or something like that. And that would be more towards the line of OT. And would it be good to get some more, you can go out and say, hey, can you come in and be part of this study? That would be more, I don't want to say abnormal, but not.
yeah, we're doing that.
So.
We're doing that. So the other controls, we will steal them from the movement disorder clinic. So it'll be people that will have same age and same, characteristics, I guess, and you all, and that'll be helpful, I think. But beyond that, the only thing that would take you out of the study as a control is if you have a known stability problem, vertigo, and things like that. So we're very open and we're gathering, the idea is to differentiate normal population with OT, and the normal population is, anybody. So we're including all sorts of people. But none of the controls were normal. See, it doesn't exist. Let me clarify that before you go say that. Before I get a riot against me. There is no such a thing as a normal neurological exam. Okay? Everybody has something. Everybody does. And so that's the way it works, because, you can ask my wife, I have a lot of abnormalities. Okay. Any other questions?
I've written this one down because I want to get it right. This has to do with a subjective way of testing. When I am asked by a medical person, has your OT gotten worse over time? It's so subjective. So what would be both an effective and objective test, or a series of tests, that the OT patient could perform on him or herself, either alone or with the help of one other person, that would provide a baseline check on the progress of his or her physical deterioration? I'm looking for something that one can do in the privacy of one's home that produces a measured result quantifiable as numbers, which could be recorded in a written record and tracked over time to get a sense of how the disorder is getting worse or getting better. It could also be a measure of how well or how poorly a medicine, a treatment, traditional or alternative, or an exercise regimen, is doing in reversing, slowing, or advancing the undesirable symptoms of the OT disorder.
Very good. Wow. So, everybody got that? I'm going to summarize it in two things, okay? Or I guess I can summarize that in one, but I would produce two problems out of that. The question is, do we have a way of measuring OT properly? Right? Measuring the severity of OT properly. Is that important?
Yes.
It is extremely important, right? Because how are we ever going to be able to properly study treatment options and decide that the treatments were or not useful on patients with OT, right? See, in patients with a stroke, we want to prevent strokes. We give a drug to prevent the stroke, and the way of testing is, in 5 years, did you get a stroke? So you did, you're bad. You didn't, you're good, right? In OT, we need to measure a continuum of disease. So that's the question, okay? So one of the objectives of the study is actually twofold. To develop not only a severity scale, which is important, but to develop a true diagnostic criteria that is closer to OT. And we were talking about that this morning. The way of diagnosing OT right now is is not easy, okay? They give you two symptoms. You have to have them both. If you don't have those two, you don't have OT, okay? And you have to have a confirmatory test through EMG, the very special surface EMG that very few centers in the world are able to understand. That makes the diagnosis extremely hard. The way OT is being evaluated is using things that have been properly validated as a severity scale, okay? And what you are asked is to say how bad this is in a scale of 1 to 10, right? And that has been studied, but it's not specific for OT. So you're right, that's something that needs to be developed. And beyond that, it needs to be validated. You saw the people doing the finger rubbing for checking your ears. I developed that study. It took me 2 years, 1 year in the lab and 1 year testing it in patients, to be able to prove that finger rubbing was good enough, reliable, and appropriate testing, to be able to see that. And we compared 400 ear results, 400 ears, with their audiograms. So every patient that underwent that went to get an audiogram, which is the formal testing, and then we compare the two results. How good is finger rubbing, how good is the audiogram, and and we see how to do it, right? Well, the problem with OT is that we have a gold standard, which is the EMG, right? So we will need to produce a scale that then we can compare with the gold standard and see how good is it to, produce the diagnosis, and how reliable it is in terms of severity. But because we don't have a biological marker of the severity of the disease, we don't, right? There is no way to do a test, an EMG, an EEG, something biological, measurable, and say, this is how bad your OT is, right? That a severity scale will be very, very hard to develop. Because, yes, I can develop one, but I cannot prove that, in fact, that is true with what's happening inside the brain of the person. Yeah, so it's going to be very difficult. But we'll attempt, we'll work on it. Yes, please.
Does the severity have anything to do with like the change in the, whatever, like the Hertz numbers, whatever that is,
No.
in terms of the cycling? I mean, if you cycle slowly or cycle fast, that doesn't have anything to do with the severity.
The question is if the frequency of the tremor has anything to do with the severity, and the answer is no. And the frequency of the tremor is specific to each person.
And that does not change.
So your tremor is 13, and say Peggy's tremor is 18 hertz, frequency per second. It will always remain so.
Okay,
Or
so
at least-
that will not change even though you feel like you're getting worse.
That's right.
Okay.
Well, or at least that's what we think. It has never been properly studied.
Because
But-
there's so few of us, there hasn't been enough testing.
Yeah, so to be fair, that's what we think. I mean, I have read it in papers.
So I got the impression that it would go up gradually.
No. So, okay, yes, please.
Now, you mentioned before about the stimulation in the brain that caused that action into a normal person, that it would indicate that that person had OT. Is that correct?
Run that by me again.
You have indicated that there has been some testing done where you can apply electricity or whatever, that people would show that they had OT, that would have the same stimulation in their leg. Is that what, or am I totally wrong?
In a normal person.
Going back to when you said
In a
you
normal
stimulate the
person.
brain.
Yeah, but that's in a normal person. Yeah,
In a normal person, they stimulate the brain and causes the shaking in the legs.
that's right.
Has there been any other study anywhere else in the body, somewhere in the spine or so, that would
Yes.
be able to cause that same situation?
No. There has been studies done stimulating the spinal cord, stimulating the specific limbs, stimulating the arm, the legs, and seeing if the tremor would occur, and it didn't.
But
It's
there
a brain
has
process.
been- But hasn't there been testing where they stimulate, like the electric shock makes your toe turn, and then they saw that all the pathways were working normally? 'Cause
Yes.
I had that test to see
Yes.
if everything was working normally.
And that's why I said that
shows-
that the sensory system has been evaluated over and over again on these patients and has been shown to be normal so far. Now that doesn't mean that is truly normal, right? The scientists, what we would say is, using current methodology, we are not able to find a sensory abnormality in patients with OT. But that doesn't mean that it's truly abnormal, right? Yes.
But didn't you also say that there's been 4 or 5 people that have had something implanted in their brain which has stopped the OT?
Yes, it has improved the OT, and that's the deep brain stimulation surgery, which is the same surgery that is used for Parkinson's disease and essential tremor, and that can help tremors overall, really, and it can help OT tremors as well.
One of our members reports that he was in the hospital for a protracted period of time and undergoing continuous oxygen use. And his OT symptoms completely disappeared, and for a time afterwards completely disappeared. Is there any relation in your mind, or any possibility of investigating a relationship between oxygen therapy and tremors and OT?
Well, that's a great question. So anytime I hear something like that, okay, not that I don't trust on you, but I don't trust on you.
Of course.
Not that I don't trust on your doctors, but I don't trust in your doctors, right? when you came to us, we made sure that we reviewed the signs and symptoms of OT and decided that you had it by ourselves, right? By our standards. So I don't know if that patient actually has OT or not.
Yeah.
Yes, he
Right.
does.
That was
But-
Mike.
That was
I had
Mike.
told you about Mike. I had emailed you. That happened about 2 years ago.
Spain guy?
Yeah, he's a guy
Yeah.
in Spain.
Yeah.
I had emailed you, and you had actually emailed, Mike had emailed you then.
No, I know, but what I'm saying is, so I haven't seen
You haven't
him,
met him.
right? I haven't seen him. I don't know what he has.
You'll meet him.
But he has seen good experts. But beyond that, the way of designing a study like so, would be you cannot go to a hospital because maybe Mike, and I know this as a fact because he was very sick, he was lying down in bed for a long time. And we all know that resting makes things better. In fact, if you're shaking a lot, you can, and I saw this over and over again, the patients would ask me, doctor, I'm going to sit down for a little bit. Just give me a second so I can recharge my batteries, right? And you sit down and woo, go, let's do it again, right? And you are good for 10 more seconds, but let me sit down again so I can recharge. So I wonder if lying down in bed for a long time, could have anything to do with it. And the problem is, how do you separate the two? Because when you go to a hospital and you receive oxygen, you're also receiving 100 other things, right? You're getting an IV. So I could say, if you go and get an IV, you can get better, right? There are so many associations that you could do in a hospital setting because there are many things that were out of the ordinary for him. It could be the chef in the kitchen that use more pepper than normal. See, so scientifically speaking, that's the way we think about these things, and it is very hard to make associations.
Well, the reason why his account resonated with me is that I had been studying at the time a method of treatment that's more popular in Europe than it is in the United States and Canada called ozone therapy. And it obviously involves oxygen being introduced into the body by various means, an enriched source of oxygen. And I'm wondering if that ozone therapy holds any potential for either not a cure, but some relief.
Mm-hmm. Yeah, I have a lot of interest on that. So I'm not saying that is completely crazy and that Mike is out of his mind. I just sent to the American Academy of Neurology an abstract on a kid that had a major brain injury when he was 29, and he was very disabled for many years. And he came to see me, and his dad begged me that he wanted the kid to go through hyperbaric oxygen treatment, right? And the problem with this guy is that he's Cuban, and Cubans are persistent. And he talked to me into doing it because, he told me this. He said, "Doctor, is there anything else that you can offer?" I said, "No." And I said, "If you would have a son with this, would you try it, right?" And I said, "Hell yes, let's go do it." So I had to go and convince the hospital to give me $120,000 to be able to do this because it's extremely expensive. The first reaction was, "Are you out of your mind?" But they ended up paying for it. And after 4 years of the kid being unable to remember if he showered or not, unable to walk by himself, and unable to drive, and unable to have a normal life, we did the hyperbaric oxygen, and his dystonia went away, his movements normalized, his memory got normal within a matter of 3 months, and he went back to driving and he's working, right? So it was 120 treatments. So because you do it every day for many days. Okay. But we had no hope of recovery with him, right? After so many years of the injury, you are not expecting improvement. There are two options. Hyperbaric oxygen worked on the kid, or it was a miracle. And I don't believe in miracles, but So we're reporting that. So I am in line with the same thinking that, my mother told me when I started medicine, she said, son, I'm going to give you a couple of recommendations. Number one is listen to the mother of the patient. Number two, listen to the wife. And number three, if with water you are curing, water keep on giving. And I have followed that to heart, because you have to believe on the family. You have to listen to the patient and the patient's environment, because you will gather information and really actually improve your care. And if they tell you, I got oxygen, I got better, we have to investigate those pathways. But what I'm saying is that, I could make up so many ideas on why the hospitalization was useful that, we have to go about it. Okay.
I know exercise is important and muscle tone is very important, but are we really seeing that the tremors decrease with better muscle tone, and are we able to stand longer with better muscle tone?
That has not been properly studied. That has not been properly investigated. My therapist and even my wife, she was volunteering yesterday there, and she told me, how old is that lady? And I said, well, she's 82. And she said, what? She looked like 60. I said, well, that's my patients. Because my patients, they see a mechanical escalator on the right and a bunch of people hoping on there, and they see a regular escalator on the left, and they're going to get the regular escalator. Help to, because they see an elevator, and a couple of stairs. They are always going to, there are so many things that you do that keep you guys active, right? So I don't know. I might venture to say that you are one of the most active people at your age level. Just because you never stand, you're always on the go. I'm just thinking, Helen is one good example of that. So I have to make a confession. I don't have time to review all of my emails. And my wife is my greatest partner. She reviews my Facebook on a daily basis. And she reviews my email, my personal email. The work email, she doesn't, she has no. But my personal email, she does. And Peggy emails me to my personal email, right? And Peggy always keeps me up to date. And she's like, I'm doing this. And oh, by the way, I did this. And oh, by the way, I'm doing that, And my wife asks, so how old is Peggy? Is she in her 30s? And I'm like, oh, no. Because Peggy, she's hoping on anything that she can, She's, doing curl and, kayaking and, biking. It's just amazing. So I think that you guys keep very active. But borderline, the study has not been done. So.
What's the future for this group? Are you going to call us back and do some of the things that's in the future?
Great question. So are you going to get rid of me is the other way of I already have some. I woke up this morning at 7, my eyes were like, and I said, how in hell I forgot to ask this question? I had a very important question that I needed to ask that I didn't, right? We have already had 3 of those. Now we had, out of all the questions you guys went through, we actually eliminated 200, and we kept about 300. Because, we had to limit this. But there were some that were essential that didn't come to us. And so for the next batch that is coming, I will have to get permission in the IRB to ask the IRB if it's okay to, for me to add these new questions. And, the new batch will get all of those new things. And then I also have to get permission to recontact you for those other questions. See, you're so protected. You sign up for something very specific, right? So before I go and start bugging you again and emailing you and things like that, I will have to get all of those permissions. And that's the way it works. But am I planning on doing that? Yes. I'm such a pest.
No, we're very great.
Any other questions? Any other questions?
I think that's what it is. I just want to say final thanks
All right.
to Dr. Rosado. We just
Oh,
really
that
appreciate
was-
everything.
Thank you.